I'm Dr. Gary Zammit, President and CEO of Clinilabs, a full-service contract research organization that's focused on the development of CNS therapeutics. With me today is my friend and colleague, Dr. Harold Murck. Dr. Murck is a professor at Philipps University in Marburg, Germany, and he's also the founder of Merck Neuroscience. Harold, welcome.
Yeah, Gary, thanks a lot for the opportunity to talk to you today.
I'm looking forward to talking to you today about the topic of depression. But before we get into depression per se, I'm kind of curious about your history and background and what led you into this area of research.
I'm a fairly scientific-driven person. After school, I actually studied physics for a while. I think I got the basics, and also I think it's a good ground to learn how to make arguments and to come up with reasonable solutions in science. I then started to study medicine with really the clear perspective of becoming a psychiatrist or a neurologist. I was pretty clear that I wanted to do something in the area of neuroscience. I did then my MD thesis. In Germany, I actually have to do some academic work in order to get the title of an MD. When I then started to be my training in psychiatry, I actually went to the Max Planck Institute of Psychiatry, which I think is a very important place, and was there for about 7 years, did quite a bit of research, particularly focusing on depression, but broader than that, using EEG methodologies, particularly polysomnography, in combination with neuroendocrinology. And then after I did my training, did quite a bit of research, I thought it would be nice to do something more practical. So I found my way into the industry. I started at a small company in Berlin at the time with around 300 people. I was working on a compound where the challenge already was to find the right patient population for this kind of unusual compound. And this actually opened up my thinking for what is nowadays called personalized or individualized medicines. I did quite a bit of work in the US here I was for 3.5 years in Scotland in the meantime, working at a small company focusing on an omega-3 fatty acids in depression and in Huntington's disease, which was an interesting small group. We learned quite a bit about that, moved then to the US in 2006 and was both in small and in big pharma. And over the last couple of years, I was really focusing on smaller type of startup companies just to put my expertise into the best use, if you want so. So that's what I did over the years.
Very interesting. So you've done work in basic science, in clinical science, and also in therapeutics and industry. So your background is pretty diverse.
Yeah, but the important thing is that it stays interesting, yeah? Many people say that I also would agree with this, that we are in a really interesting time in neuroscience. There are a whole bunch of new modes of actions and mechanisms which are explored these days. So there's a lot to learn, and there's always the opportunity to find out if the mechanism which you have in your head is somewhat connected to what other people state is the real thing, if you want so. And more often than not, you actually find reasonable connections between those areas of interest. So I think that's quite interesting to see that there is, at least at some level, a certain consistency between what different people are doing. However, there's much more to do and much more to learn in order to move forward with what everybody strives for, this personalized treatment approach, the identification of the right treatment for the right patient. And at least we started it a while ago. Yeah? And I think I was part of that movement, if you want so.
Yeah, it's interesting. I feel much the same way. There is so much to learn, so much to do, that if we do a good job, we're guaranteed work for the rest of our lives. There's a lot of work to do. But let's focus in now on depression. And for those who might need to put this term in context, how do we define depression, and how is it different from that feeling of low mood that people might experience from time to time in their day-to-day lives?
All psychiatric diagnoses, including depression are constructs, which is based on a certain level of clinical experience, a certain way to characterize them biologically. But of course, the first and foremost thing to keep in mind is that is a very heterogeneous disorder. And this is actually reflected in the way how depression is diagnosed according to standard catalogs like the DSM-5 or the ICD-11. So basically, you have to have a depressed mood. And what became more fashionable over the last couple of years, you have a lack of pleasure, so anhedonia. And then you have a bunch of additional criteria which may differ quite a bit between people. If you look into these catalogs, you can have sleep disturbances, which means you can have either too much sleep or a lack of sleep, particularly with early morning wakefulness. You can have changes in appetite, which means you can increase more or you can eat less and have a weight loss, which is related to the typical melancholic or endogenous type of depression. There are psychomotor disturbances. And there is this sense of hopelessness. I think that's a really important one, which then is connected to suicidality. And of course, suicidality is really the most difficult situation to deal with and the worst outcome in patients with major depression. So at the end of the day, if you are treating patients with depression, the aspect of the risk of suicidality always has to be in your mind. Some additional criteria related to the diagnosis of depression, which has to do with the fact that it cannot just last for an hour or a day or a couple of days, but it has to last for at least 2 weeks. So major depression is a life-threatening disorder. It's a disorder which, of course, affects the perspectives in life and therefore suicidality. But I think some of the things which are really important and which we have to keep in mind and also allow us to characterize potentially different forms of depression is it's not a brain disorder per se. Major depression is a disorder of the whole body. And I think that's something which we need to keep in mind. There are, of course, these changes which are related to the behavioral aspects. Sleep disturbances, on the one hand, can, of course, lead to certain changes in bodily activity. People are tired in a way. Hypersomnia, the same thing. Changes in the patterns of eating, particularly in this form of so-called atypical depression. You have situations where people eat more than usual, particularly sweets. Carbohydrate craving is an important aspect. So this has aspects based on the behavior and leads to bodily changes. On the other hand, I think it's important to keep in mind that the body in itself feeds back on brain function. So what we know now is, for example, that adipose tissue is not just sitting there and stores fat, but it's actually endocrine active. It produces inflammatory parameters. It produces neuroendocrine parameters, particularly aldosterone, which is an area which I'm particularly interested in. And these parameters reflect or induce changes in the brain, which then can lead to a feed-forward cycle to actually make the situation even worse. So I think it's important to keep in mind that if you exclusively looking at the brain and what's happening there, you miss a whole bunch of opportunities to intervene and make things better, but also you really miss the opportunity to characterize the full neurobiology or broader, in a broader sense, biology of a disorder like major depression.
Well, I'd like to ask you about that because one of the points you made is that people experience depression differently and may present differently, I think, in the clinic. But is there an underlying neurobiology of depression, and is there a heterogeneity in that neurobiology? Is something happening biologically differently for different people?
The classical characterization can oppose the so-called melancholic or earlier called endogenous depression with what is now called atypical depression. So in melancholic depression, it's a classical textbook depression where you have the specific type of emptiness, this feeling of feelinglessness, where you typically have weight loss, where you have early morning awakening, certain psychomotor changes. And this is, I think, the form which originally was targeted with psychopharmacological treatment. So if you look into the early treatment trials, they were looking into patients with melancholic or endogenous type of depression, whereas in the 1960s or so, it was clear kind of that people who don't have these endogenous or melancholic types of depression rather should be treated with psychotherapy. So there were studies done up into the 19th. Phase comes to mind, looking into EEG, polysomnography aspects to differentiate which patient would benefit from which kind of treatment. But of course, then with the advent of the SSRIs and the much better tolerability, people kind of forgot about this differentiation. So a very heterogeneous bunch of patients were put into trials, which didn't really help the outcome of clinical trials, because if you induce variability, the chances of having a positive outcome are much less than if you look into a very specific type of depression. But coming back to the neurobiology behind it, atypical depression goes along with hypersomnia, too much sleep, eating too much, weight gain. And this is reflected in the typical signs of inflammation. You have that in the inflammatory signs and symptoms of atypical depression, which goes along with an increase in weight and the consequences potentially of increased adiposity. And you see a bunch of biomarkers related to neuroendocrine changes. You see an increase in a hormone which comes out of the adipose tissue called leptin, which you can identify. You see changes in blood pressure regulating symptoms. There's this angiotensin converting enzyme, which is targeted typically with blood pressure medication, which is increased in atypical depression. Whereas in melancholic depression, you see the often cited increase in cortisol, which you don't see in atypical depression. You may actually rather see a reduction in cortisol. So even on this very basic neurobiological, neuroendocrine aspect, you can match the certain aspect, at least, of the clinical aspects of these disorders with a certain neuroendocrine and neurobiological underpinnings. And I think that's important to keep in mind. Again, this gives us the opportunity to objectively identify patients who may benefit from one treatment versus the other.
So this has implications for clinical trials and how we define patients that go into these trials?
Yes, absolutely. You have to find the right patient. And at the end of the day, you cannot force a p-value out of a heterogeneous population when you treat them with a compound which may just not match the neurobiology. There was, of course, a time back in the 1980s, early 90s, when people believed that there was, as my former boss, Florian Holzbauer from the Max Planck Institute said, there was a final common pathway which leads to depression. I don't think there is such a thing. I think there is just a very heterogeneous neurobiology, and you have to deal with this neurobiology and identify these subgroups from the start. Final common pathway is an interesting thought, but I don't think this has been proven in any way.
Would you envision clinical trials that are designed to, say, include only patients who are defined as what we used to call melancholic or endogenous depression, or those that might be positive on a specific biomarker, a neuroendocrine biomarker for depression? Could you envision trials being designed in that way?
I think that's the way to go. There is a bit of resistance to doing that, because if you define a subgroup, you end up with a smaller patient population for your label. That's always something which you have to consider, and there's a good reason to consider that. You don't want to limit yourself in an unreasonable way, of course. So you have to be fairly clear what are the limitations of the indication or this particular type of depression you are looking at. But there are fairly simple biomarkers, and just from my own research, things as simple as blood pressure seem to define different forms of depression. It seems that subjects with low blood pressure don't respond to standard antidepressants, at least when they are hospitalized. I mean, it's a study which I did and which was replicated with several hundred people. And this shows that a lot of things which are happening in depression are not necessarily primarily cortical, but the pons, the brain stem where autonomic regulation happens. And again, an area which allows us to measure really quite a number of biomarkers related to autonomic characterizations can help us to find the right patient population. So the autonomic markers, things like sleep duration, I think, have an important impact in some way related to this differentiation between melancholic and atypical depression. I mentioned inflammation already. There is quite a bit of literature out there to say if you have higher simple markers, C-reactive protein, you are probably less likely to respond to an antidepressant. And of course, neuroendocrine markers play a role. Cortisol has been studied extensively. I think it's important to keep in mind that cortisol, first and foremost, only is increased maybe in a third of all of depressed patients. And I think that the idea that cortisol is a causal factor for the generation of depression is a problematic standpoint. Major depression has this cyclic aspect. It is there for a while. It can be quite severe. It can lead to suicide. But at the end of the day, in most cases, it gets better after some time. So I think this is an aspect which needs to be kept in mind. And there are different forms of depression which have a different natural cause, which means if you mix up these different forms, you induce a lot of variability. So that in itself is already an important aspect for a clinical trial to make sure that you have a similar group of subjects which show a fairly similar, at least expected, natural cause in order to reduce this variability. And so, as I said, autonomic markers, inflammation markers, neuroendocrine markers can help in order to increase the homogeneity of this population and may actually allow, as you pointed out before in your question, to identify the right patient, which may actually be specifically responsive to a certain medication. And I think there are some people working on these types of aspects at this moment in time.
Mm-hmm. It seems to me that that brings us kind of one step closer to personalized medicine, that the characteristics of the patient are better and better defined, and then we determine whether or not that particular type of patient responds to an antidepressant.
That's exactly it. So I think there are different ways of doing it. Of course, in the best of all worlds, you would identify the patient before he ever or she ever was treated with an antidepressant. That's somewhat more challenging, but can be done, but more research is required. I mean, what can be done somewhat easier is to, after a short period of time, let's say a week or two, see if there are certain changes, neurobiological changes, which may then indicate a predictor of a clinical response further down the line. So more a marker of target engagement, I would say, not necessarily a causally related marker, but a marker of target engagement. So you see something happens in the brain, in the neuroendocrine pathways, in metabolic pathways, and this then can help to identify which patients are sensitive to this specific type of manipulation. Yeah?
Right. So something that could improve on what would otherwise be trial and error.
That's exactly it, yes.